We'll move on to, thank you very much. Item 4265, under the Department of Public Health. Got quite a few issues that we'll be hearing, one of which will require a vote, members. We'll start with the overview. Page 20 on the agenda.
Good afternoon, Madam Chair, members of the committee. I'm Daniel Kim, the Chief Deputy Director of Operations for the Department of Public Health, and I want to thank you for this opportunity to provide the departmental overview, to share some of the challenges that we face and how we plan to address those. I want to first thank the budget consultant for such a detailed write-up of the Department of Public Health, so I won't repeat all the numbers and information there, but I would like to briefly state that our department has a budget of $3.1 billion, over 3,800 staff working in over 200 different programs to help promote and optimize the well-being of the people of California. Now, all these 200 plus programs are important and necessary for California, but we understand and recognize that there are certain public health threats that are of greater interest and pose greater risks. So we wanted to share with you right now 9 of the more pressing issues that we're dealing with in 2015. First is Ebola and emerging infectious diseases. The department continues to coordinate a statewide system to monitor travelers returning from Ebola-affected countries. To date, we've gone ahead and monitored around 350 people successfully through our system. We're working with our health systems to identify 8 Ebola treatment centers, treatment hospitals in the event of a suspect or confirmed Ebola case. And in the coming months, the department will be developing a plan to distribute federal funds to ensure that California can monitor travelers from Ebola-affected countries, transport suspected cases, isolate and evaluate them, conduct lab testing, treat confirmed cases, and ensure the protection of our healthcare workers. Second, we're also in the midst of the largest measles outbreak in the U.S. since 2000. Since December 2014, we've had over 130 reported cases of measles. Fortunately, that number of cases has slowed, thanks in large part to the work that the department and our local health partners are doing to curb transmission or infection. Our staff are working to support local efforts to identify exposed persons and to provide testing, consulting, guidance, monitoring, promote vaccination, and to generally coordinate the statewide response. We've also done similar efforts like this with whooping cough, and we plan to do more efforts like this with other infectious diseases like multi-drug-resistant TB, dengue fever, and chikungunya, among others. As you heard earlier, the department is also very engaged in the discussion with hepatitis C and HIV. Every year, about 5,000 Californians become newly infected with HIV. That's about 14 people per day. We want to stamp out HIV by ensuring access to care and treatment, which will also help reduce the rate of HIV transmission. We also want to address Hep C, which kills more people each year than HIV does. And we'll be working with other state departments and stakeholders in the coming months to develop a more comprehensive statewide approach to high-cost Hep C drugs. Fourth, we are working on licensing and certification. As you know, the legislature and stakeholders have raised many concerns regarding the timeliness of LNC investigations. The department's recently hired a consultant to conduct a program assessment. That consultant's provided recommendations, and we're in the process of prioritizing those recommendations and taking steps towards implementation. I'll be speaking on this a bit later as well, as will Gina Icino, our newly appointed Deputy Director for the Center for Healthcare Quality. Fifth, e-cigarettes. The department's very concerned about the health risks associated with e-cigarettes. This January, CDPH issued a health advisory and a report warning Californians of the toxicity of e-cigarettes, which contain nicotine and other harmful chemicals. Now, preliminary reports suggest that school-aged youth are using e-cigarettes at a rate 3 times higher than their use of traditional cigarettes. So we're very concerned about this and plan to further investigate this and the health implications associated with e-cigarettes. 6, foodborne illness outbreaks and food recalls. Our department has a major role in ensuring food safety. We investigate foodborne outbreaks, and we help the food production industry operate safely and successfully in California. Along with the feds, we have formed the California Food Emergency Response Team, which now is a model for the nation. But we continue to see a growing number of foodborne illness outbreaks in California. Seventh, our department is committed to helping children get a healthy start. We've pioneered many best practices that are used around the nation regarding reproductive and infant health. We have our California Home Visiting Program, where we've successfully piloted this program in 20 counties. We are actually augmenting it in 3 additional counties. And this program supports first-time at-risk mothers so that they can help their children get to a strong start. Our newborn screening program is renowned nationwide, and we've saved lives and millions of dollars by early detection and intervention of genetic diseases. We'll be advancing new screening methods and continuing our collaboration with academia and researchers throughout the years to come. So we've worked on a number of different areas in that with respect to infants, and as a result, we've seen rates of C-sections, preterm births, and infant mortality decrease pretty much every year. In fact, as a result of our efforts, California met the nation's 2020 premature birth rate goal a full 8 years ahead of schedule, and we're just one of 6 states to receive an A grade by the March of Dimes. The department is also continuously looking ahead to see how we can promote ways to optimize health. We are taking a lead role in the governor's Let's Get Healthy initiative, which will help make California the healthiest state in the nation by 2020. Our department is the lead in developing the Let's Get Healthy California website, which will enable the public to see the progress made in various health indicators. We as a department also serve as a convener on a number of cross-cutting issues that require a coordinated effort. So we have taken the lead in the prescription drug overdose work group, which is comprised of several state departments, along with a number of medical boards and the pharmacy board. And we're trying to raise awareness and reduce the rate of prescription drug overdose. Also, through our Office of Health Equity, we're looking for ways to collaborate both internally and externally to better address health disparities. And last, just want to mention our open data and transparency efforts. Our department's been a leader both in the state and nationwide in promoting open data. Through our nationally recognized open data portal, we've been able to offer the public access to various health data. Our intent is to help inform the public so that they can harness this information to make more informed decisions about the community and about their personal lives. So these are some of the issues that we're dealing with right now. I also want to mention that as of December 2014, our department became just the 7th state health department to be awarded accreditation from the Public Health Accreditation Board. This accreditation process measures a health department's performance against a set of nationally recognized practice-focused and evidence-based standards. To achieve accreditation, a department must undergo a really rigorous, peer-reviewed assessment to ensure that we meet a number of different quality measures and standards. For our department, we actually submitted over 1,100 documents, totaling over 19,000 pages to demonstrate our quality and to ensure that we achieved all 105 measures of quality. The Public Health Accreditation Board that came and reviewed our department applauded CDPH, and I quote, they said, "CDPH demonstrates exemplary performance across the entire framework of FAB standards. The department's programs and strategies serve as a national model. Department leaders have created a culture of quality, professionalism, and service that is visible throughout the agency." So we kind of liken this to getting a report card on 105 different subjects, of which the vast majority we received an A on. So now our accreditation status and the national recognitions that we've received seem a bit at odds at a recent designation by the state auditor as a high-risk department. So you must be wondering, what is it?
You've read my mind.
Does one or the other completely miss the mark? I just want to say that that's not necessarily the case. Maybe I can provide a little bit of context to that. First of all, the FAB accreditation did not include licensing and certification as part of its review. And if you look at the high-risk...
And does the national accrediting entity not include that because other departments of public health across the state don't have that responsibility?
A lot of other state departments, state health departments do not have that function.
Got it.
So they were just trying to compare apples to apples. Also, if you look at the high-risk department assessment by the state auditor, over half of the outstanding audit findings were in two program areas, one of which was licensing and certification, the other which was our lab field services. So I think what we'd like to do is we recognize that we have a number of outstanding audit recommendations. We're making concerted effort to address those, and I'll speak to those briefly. But we also note that we have over 200 other programs that have no outstanding audit issues. So I hope that provides some context. With respect to licensing and certification, what are we doing there? And as I mentioned, Gina Isina will be speaking more to that as well. But within that program, we're taking numerous steps to address the issues identified by the state auditor. Staffing is one of the most significant issues, and we have before you budget change proposals for additional positions, up to 240 additional positions for our department, along with an augmentation to the LA County contract to address the workload demands within those programs, and also to reduce the number of pending cases that we have and expedite the cases that we get. We also want to improve our data collection methods so that we can better track the timeliness of the investigations. And we've developed and are continuing to develop performance metrics on the volume, the timeliness, the disposition, and quality of the investigations that we conduct. We currently post our metrics on our website, and in the next round, next quarter, we plan to break out the data by district office. We're also very cognizant of the fact that if we focus so much on speed, we can do that at the expense of quality. So we want to look at the criteria for reviewing complaints and ERIs, and we want to make sure that we look at the quality aspects as well by conducting monthly reviews. We're going to do some sampling of complaints and ERI investigations in the LA County contract offices, as well as our own district offices. We also plan to we are conducting quarterly visits to each of our district offices to discuss with the district staff ways to better execute policies and procedures. And we also want to update our written policies and procedures, identify which district offices have the best practices and incorporate those into our standard practices and standardize those throughout the department. With respect to lab field services, we're also taking a number of different steps to close our open audit findings. One is within lab field services, we have a challenge with our hiring. We have a number of vacancies. And so we're looking at ways to work with our own HR branch to see how we can expedite the hiring process, improve our recruitment strategies, and the like. We're also in the process of revising a number of different policies and procedures related to out-of-state licensing, sanctions, complaints, and meeting licensing requirements. We hope to get most of these done this calendar year, and these are the bulk of the outstanding issues that we had with state auditor with respect to LFS. We're also working with our IT services division to automate some of our manual processes. That should happen this year. And the LFS program has dedicated one position to write regulations because we have a number pending in that area. And we're also having LFS partner with our own internal audits unit so that we can vet our issues to make sure that we have complied with the state auditor's findings. So those are a number of things that we're doing to address our high-risk department designation. Thank you.
Thank you. Any questions from members before we hear from Finance or LAO? Nothing? Yes, Monty.
So first I want to thank you for the comprehensive overview, and certainly the department is the umbrella for multiple programs and campaigns. You did focus on the current efforts around measles and pertussis. Do you have at your fingertips today just a quick update on where we are with either of those and what the department's doing to promote appropriate vaccination protocols?
Sorry, I'm not a clinician, so I can't speak to that personally, but I can get back to you.
Yeah, that's fine. Again, it's kind of beyond the scope of our oversight today, but it has been so much in the public eye. So any kind of progress reports, it's been an issue that's generated some public debate and discourse about the utility of vaccines. And I think what should drive the public debate should be science and public health interests. So anything that the department can provide us while this is being debated at sometimes hotly in our communities, it'd be helpful to me to know what current update from Department of Public Health. So thank you.
We'll do that. Thank you.
Thank you. Any public comment? Seeing none, we're going to move into items, I think, 2, 3, and 4, because they all deal with the Office of AIDS. First being the ADAP program. Then we'll move on to client eligibility, verification resources, and modernization. I'm going to hold public comment to the end of all 3 of those around Office of AIDS, so the public can be notified. Good afternoon.
Do you want to press this? Good afternoon. There. Hi, I'm Dr. Karen Mark, Chief of the Office of AIDS, and I have with me Nikki Dillon, the ADAP Branch Chief.
All right, and then
Many thanks to the Senate staff for providing a wonderful summary. The Office of AIDS is responsible for all of CDPH's HIV surveillance activities, keeping track of the number and demographics of the approximately 5,000 Californians newly diagnosed with HIV every year, 140,000 Californians living with the disease, and 1,400 HIV-infected Californians who die every year. We are also responsible for all of the HIV prevention and medical care and supportive services that are funded through the department, as well as the AIDS Drug Assistance Program, or ADAP, which provides life-saving medications to eligible Californians living with HIV and AIDS who have no other payer source for them. I'll present the ADAP estimate first, and then the budget change proposal. So to summarize the significant changes to the ADAP estimate, in 1415 Budget Act included ADAP local assistance funding of $440 million with no state general fund appropriation. The revised 1415 budget is $384.9 million, a decrease of $55.1 million, which is mainly due to 3 factors: a larger number of clients enrolling in Covered California during 1314 than was initially estimated, a larger number of clients transitioning to Medi-Cal expansion during 1314 than was initially estimated, and fewer clients accessing hepatitis C treatment than was initially estimated. The revised current year budget does not include a general fund appropriation or any cuts to services. The proposed funding for the budget year is $415 million. The Office of AIDS estimates that expenditures will decrease by $25.1 million compared with the 1415 Budget Act, but increase by $30.1 million compared with the revised current year. The increase compared with the revised current year is primarily due to new clients enrolling in ADAP. ADAP clients will continue to transition from ADAP paying the full cost of their medications to Covered California and Medi-Cal expansion in 1516. However, the Office of AIDS expects that the number of clients leaving or changing client groups will stabilize and that client caseloads will again increase due to people being newly diagnosed with HIV. Changes to the ADAP budget authority when compared with the 1415 Budget Act include an increase of $10 million in ADAP rebate funds, an increase of $342,000 in federal funds, and a decrease of $35.5 million in safety net care pool reimbursement funds. As always, the numbers in the estimate will be revised with updated information during the May revise, and there are no new policy changes included in the proposed budget. So to give an update on the transition of ADAP clients to Medi-Cal and Covered California, just to remind everyone, by the end of 2013, most former ADAP clients who were eligible for Medi-Cal expansion had already transitioned from ADAP to the low-income health programs, or LIPs. And on January 1st, 2014, these clients transitioned from LIP to Medi-Cal expansion. The Department of Healthcare Services oversaw this transition, but we worked closely with the Department of Healthcare Services and our stakeholders on the Office of AIDS, Department of Healthcare Services Healthcare Reform Stakeholder Advisory Committee to ensure that the smooth transition of HIV-infected LIP clients into Medi-Cal expansion. On January 1st, 2014, a relatively small number of ADAP clients who had not previously left ADAP for LIP became eligible for Medi-Cal expansion. These clients transitioned directly from ADAP to Medi-Cal expansion over the course of the calendar year 2014. These included ADAP clients who exceeded the LIP upper income limit in the county in which they resided. So if you recall, some of the county LIPs had an upper income limit below 138% FPL, or they resided in counties that did not implement a LIP. In both the fall of 2013 and in the fall of 2014, ADAP sent a letter to all ADAP clients who are potentially eligible for either Medi-Cal expansion or Covered California with information about both programs and application instructions. We also developed a flow chart and provided training to ADAP enrollment workers outlining which ADAP clients should be referred to which program. All new ADAP applicants and ADAP clients coming in for their annual ADAP recertification, which occurs during their birth month, are screened and directed towards the appropriate program. During the ADAP enrollment or recertification visit, clients who are potentially eligible to purchase insurance through Covered California are verbally informed and in writing that they can seek premium payment assistance through the Office of AIDS Health Insurance Premium Payment Program, or OAHIP, and they can enroll or remain co-enrolled in ADAP for assistance with drug copays and deductibles for drugs that are on the ADAP formulary. But as of now, clients are currently responsible for paying medical out-of-pocket costs. As we know, that will change in 2016. Clients are also informed about federal financial penalties for remaining uninsured. These procedures are designed to be in compliance with the Federal Health Resources and Services Administration, or HRSA directive, that we vigorously pursue enrollment in healthcare coverage for which our ADAP clients may be eligible. ADAP co-enrolled 913 clients in Covered California and OAHIP in fiscal year 13-14, and in the November estimate for the governor's budget, we estimated that we would co-enroll a similar number in the current fiscal year. As of March 5th, 2015, OAHIP has not seen a dramatic increase in OAHIP clients co-enrolled in Covered California. However, as we know, the Covered California open enrollment period has been extended through April 30th, 2015, and clients must first enroll in Covered California before and complete all that enrollment paperwork before they can co-enroll in OAHIP. Regarding an update on the $3 million general fund augmentation in the Budget Act, the Office of AIDS and the HIV community appreciate this budget augmentation focused on addressing the HIV prevention needs in the state. After receiving these funds in the Budget Act, we wrote a statewide competitive request for applications announcing the availability of funding for the HIV demonstration projects, and we received and reviewed applications submitted in response. 3 grantees were selected for funding: the Los Angeles LGBT Center, the San Diego County, and the San Francisco AIDS Foundation. Grantees have received their award letters, budgets have been negotiated, and scopes of work are in the process of being finalized. Using this funding, the Los Angeles LGBT Center will focus on outreach to the House and Ball community, which is a community of young gay men of color and transgendered persons, populations who unfortunately are at high risk for HIV acquisition. Interventions include HIV testing, linkage to HIV care for those who are HIV positive, and linkage to pre-exposure prophylaxis, or PrEP, which is taking 1 pill a day to prevent HIV infection for individuals who are HIV negative. The center will also be conducting linkage and retention and care activities for other high-risk HIV-infected clients. San Diego County is partnering with 3 local federally qualified health centers and the San Diego LGBT Community Center to focus on integration of targeted hepatitis C testing with HIV testing, linkage to PrEP, and implementation of a couples HIV counseling and testing intervention to help high-risk HIV serodiscordant couples, which are couples in which one member is HIV positive and the other is HIV negative, to understand their test results, access care, prevention, and treatment services. The San Francisco AIDS Foundation will focus on a comprehensive navigation to care system for high-risk, high-need clients, providing access to insurance and benefits, strengthening HIV care linkage and retention, and providing linkage to PrEP for high-risk HIV-negative persons. to provide an update on the implementation of last year's trailer bill language to pay medical out-of-pocket costs through OAHIP. The Office of AIDS is moving forward to develop and publish a request for proposal to solicit proposals from vendors who have the capacity to pay out-of-pocket medical expenses. In collaboration with the Department of General Services, the Office of AIDS plans to release a request for information in the coming week and release the RFP in the summer. It is the Office of AIDS' goal to implement the payment of out-of-pocket medical expenses starting in January 2016. Regarding the question about the projected increases in ADAP enrollment and some of the work that ADAP enrollment workers do, as ADAP enrollment workload increases, the Office of AIDS continues to consider the impact on ADAP enrollment workers and state support. In fiscal year 12-13, the total allocation for local health jurisdictions to support the administration of ADAP enrollment was increased from $1 million to $2 million because the Federal Health Resources and Services Administration required us to conduct ADAP eligibility every 6 months instead of annually. This money is allocated to local health jurisdictions based on the annual number of ADAP enrollments per local health jurisdiction. In addition, the administration has a budget change proposal, which is next on the agenda, to increase state staff support to manage increased ADAP workload. Do you want me to just go on to the budget change proposal?
I think so. We're just going to do all three because I'm sure the folks who are lined up want to probably touch on all three issues, so we'll do public comment all at once.
Okay.
So keep rolling.
All right. So to provide an overview of the budget change proposal, ADAP is requesting 5 permanent positions, 1 staff services manager 1, and 4 associate governmental program analysts, and an increase of $536,000 in expenditure authority from the special rebate fund in fiscal year 15-16 and ongoing. These positions are needed to be in compliance with the federal HRSA ADAP client eligibility verification requirements. So currently, ADAP eligibility is determined by local ADAP enrollment workers. State ADAP staff conduct site visits to monitor ADAP local enrollment sites and review a small sample of ADAP client eligibility documents. HRSA recommended after a 2013 site visit that the Office of AIDS develop a centralized electronic system with uploading capacity that would allow secondary review of all ADAP applications within CDPH in order to prevent fraud. In response, we have amended our pharmacy benefits manager contract to allow both state ADAP staff and local ADAP enrollment staff to have the ability to add, store, view, and delete scanned ADAP client eligibility documents. However, the current state ADAP staffing levels are not adequate to review all of the projected almost 35,000 client files in fiscal year 15-16. So effective July 1st, 2015, if the budget change proposal is approved, it's OA's goal to require all ADAP enrollment sites to create electronic client files when clients initially enroll or re-enroll in ADAP. This will then allow CDPH ADAP staff to verify client eligibility determinations in real time. So in response to the last proposal, this is not an administration proposal, but CDPH is always happy to provide technical assistance as requested. The proposal involves changing the ADAP income eligibility limit for both the medication and the insurance assistance programs from its current limit of an individual adjusted gross income of $50,000 annually to 500% FPL based on modified adjusted gross income or MAGI. The use of federal poverty level takes into account family size. The Office of AIDS estimates that implementing this proposal on July 1st, 2015 would cost roughly $5 to $6 million in fiscal year 15-16, but would result in savings in subsequent years. The cost to ADAP would be higher in the first year of the program change than would be expected in subsequent years, assuming ADAP's current drug rebate return rates, because of the standard 6-month delay in receiving rebate after expenditures. ADAP would utilize available rebate funds and federal funds to cover these additional program expenditures in fiscal year 15-16. The Office of AIDS estimates that 1,626 new clients will enroll in ADAP as a result of increasing the ADAP eligibility limit to 500% FPL. Of these new ADAP clients, the Office of AIDS estimates that 425 will also co-enroll in ADAP's insurance assistance programs. At this time, we are unable to determine the number of enrollees that would lose coverage based on the change in income eligibility because ADAP recently began collecting household income, and the Office of AIDS, as a result, does not have a full fiscal year of data to provide an estimate. The only clients who would lose clients would be clients who are married or in a registered domestic partnership with a substantially higher income earning spouse or partner. The Office of AIDS assumes that the number of these clients who would lose coverage would be small, and in this estimate, we've assumed it to be 0. Currently, the ADAP enrollment application process asks for family size and household income, but the Pharmacy Benefits Manager electronic application system would need to be updated to capture modified adjusted gross income, or MAGI. We would work with the PBM to make the necessary changes and conduct training for enrollment workers on the new updates. One-time costs, which would be subject to negotiation with the PBM, might be needed to implement the system change.
Any questions of committee members? Finance?